I am Dr. Sudipta Kumar Mukherjee. I am a pediatric neurosurgeon. Now talking about EDAS surgery. EDAS means Encephaloduroarteriosynangiosis, which is used for especially pediatric Moyamoya disease. Moyamoya disease is a disease which is gradually progressive, where we saw stenosis or occlusion in terminal part of internal carotid artery, usually bilateral, maybe in unilateral. And this surgery is very much effective in case of pediatric age group. So this surgical techniques for especially academic purpose to trainee and resident, I developed some composite model made up of clay, gloves, plastic, foam and paper. So now I discuss about the operation technique. At first we give skin incision. We in our center now we use incision over the scalp vessel. You saw what is the course of superficial temporal artery. Superficial temporal artery we found in front of external auditory meatus. That means here it is divided into two, and when it goes upward, it goes the upper branch is called parietal branch of superficial temporal artery, and another branch goes forward, which is called frontal branch of superficial temporal artery. For this operation we need this STAP, that means parietal branch of superficial temporal artery. And what we are doing first, we give a incision over the skin. Some give sigmoid shape or lazy S incision over the skin, but now we practice incision over the blood vessel as we detect the superficial temporal artery parietal branch by Doppler ultrasound system. So when we give skin incision and skin is elevated, vessel is exposed on galea, and the white color is galea, and we have a design to make a 4 centimeter wide and 8 centimeter long Galeovascular flap. That means we have a design to do a craniotomy of same size, but practically we saw we need a bit long flap to move the flap on one side or either side. When we open the Galeovascular flap, this is the Galeovascular flap, that is we move in one side by a gloves sealing, and we saw this is the temporalis muscle covered by temporal fascia, and we keep a collar of temporalis muscle in the upper part for better closure of bones, and by a incision here, and give a midline incision on the temporalis muscle along the course of superficial temporal artery parietal branch, and elevate temporalis muscle on both sides and retracted bilaterally by some suture material. And this is the temporalis muscle which is retracted on both sides. Now we have a design to make a 4 by 8 centimeter craniotomy, and during craniotomy we give the vertical bone cut first and transverse cut later. During transverse cut we must keep the security or safety of Galeovascular flap, and we use some a small strong instrument to protect the galeovascular flap from any type of trauma during craniotomy. After craniotomy, we found the dura here. The red color is middle meningeal artery and over the dura. So we have a design to open the dura initially by a vertical incision, then that incision elongated on upper and lower end by two transverse incision, and it's look like a capital I. And after giving this transverse incision, we divide it into 3 and 3 leaflet on both sides, and that leaflet is necessary coagulation due at the margin of leaflet. Without necessary coagulation, there is a risk of developing acute subdural hematoma. So when we invert the dural flap inside, so we revascularize the more brain, because how we explain it, because this is 4 centimeter. So if we see it from inside, see the outer surface of dura have more vascularized, so outer surface now comes in inner surface. So this is 4 centimeter, this is another 2 and 2 centimeter. So total 8 centimeter by 8 centimeter. So 60 square centimeter brain surface directly vascularized by this technique. Stop.